We get the pleasure of listening to Dr. Fedor tonight. Dr. Fedor is one of our electrophysiologists. He's been here since 2007, trained at NYU, and he's board certified in electrophysiology and cardiology.
And so tonight we're going to talk about abnormal heart rhythms, and specifically the most common of all abnormal heart rhythms, which is atrial fibrillation. And there are some patients of mine in this audience who have atrial fibrillation. Atrial fibrillation, the prevalence or incidence increases with advancing age. Less than 1% of patients who have atrial fibrillation are less than 60 years old. And more than 30% of patients who have atrial fibrillation are greater than 80 years old. A lifetime risk for a person of European origin, for a man of European origin, is 26%, and a lifetime risk for a woman is 23%. So roughly a quarter, 1 in 4 quarter chance that any person in this room will have atrial fibrillation if they don't already have it. African Americans have higher incidence of A-Fib risk factors, which we will go over in a minute. But despite this, for some reason which is not well understood, they have lower incidence of A-Fib than people of European origin. And this translates to about 5 to 6 million people in the United States who have the arrhythmia, and this is projected to double in the course of the next 25 years. So the risk factors are increasing age, high blood pressure, history of having heart attack or coronary artery disease, disorders of heart valves, obesity, obstructive sleep apnea, a history of open heart surgery, smoking, excessive exercise, excessive alcohol use, and overactive thyroid. And we'll, a little bit later in this talk and towards the end, we'll talk about some of these more, especially the ones that we have an opportunity to change, like stopping smoking or losing weight, or exercising less if you're exercised to an excess. Atrial fibrillation starts out as an episodic problem. We call this paroxysmal fibrillation. That means that episodes of fibrillation start and stop on their own. Later on in its natural history, atrial fibrillation tends to become persistent. Persistent means that it doesn't stop on its own, and it requires a cardioversion. It requires a patient to be shocked out of it. But once the patient is shocked out of it, they can keep sinus rhythm for some time. And if you allow atrial fibrillation to happen for a long period, multiple years, it can become permanent, such that even if you do a cardioversion or if you do anything, it'll come back anyway. So if you're going to eliminate atrial fibrillation, it's better to do it in its earlier stages later, rather than waiting for later stages. The most common symptoms of fibrillation are fatigue, fast pulse, shortness of breath, palpitations, which is racing, heart racing, pounding, fluttering, flip-flopping, or as one of my patients said, frogs in my heart. Chest discomfort is common, feeling faint. And interestingly, about half of all people with atrial fibrillation have no symptoms at all. They don't realize that they have it. And this can be a big problem because there's negative consequences of having fibrillation and not realizing it. So what are the biggest problems with AFib? Well, stroke is really the biggest problem. When the atrium is fibrillating, it's not really beating in an organized fashion. It's sort of quivering. We'll go over this in future slides. And what happens is that the blood doesn't briskly go through the heart, but swirls around and can form a clot. And the clot can be ejected into the circulation and then cause a stroke. Heart failure means that the heart muscle, the left ventricle, which pumps blood into the body, becomes weak. This can happen when atrial fibrillation is unrecognized for a period of time, and because it is asymptomatic, and then presents as heart failure. And then atrial fibrillation also increases your mortality. Now this is somewhat controversial. If you look at all patients in the United States who are admitted into the hospital, some proportion of them will not come out of the hospital, but they will die in the hospital. If you look at all comers, no matter for what diagnosis, you can be coming in for a gallbladder or a hip replacement or anything. If you have no history of atrial fibrillation, the chances of dying are 0.01%. If you have a history of fibrillation, that chance increases to 2.1%. But it is, even though the correlation exists, it is not clear that the atrial fibrillation is what causes the increased mortality. It is possible that patients who are sicker also have atrial fibrillation, and that's why they're more likely to die. But the fibrillation itself is not the cause. So it is definitely associated with increased mortality, but whether it's a direct cause is more difficult to establish. The biggest problem, as I said, is stroke. So essentially what this represents is a blood vessel in the brain, and this is a clot which was formed in the heart. And the clot goes down the stream in the circulation like a tree log in a river. And once it encounters a vessel which is too small, it then obstructs the vessel. And then whatever tissue was supplied by this vessel is not getting blood supply and dies. And if that tissue is in the brain, that's a stroke. If that tissue is in the kidney, and it happens multiple times, then you develop kidney disease. This can also be in the intestines, and you develop intestinal ischemia. When we look at what is the risk of stroke, we actually have a scoring system which takes into account comorbidities. So all these comorbidities that are listed here, congestive heart failure, high blood pressure, age greater than 75, diabetes, prior stroke, vascular disease, lower advanced age between 6 or 7, and then sex category, specifically females, women tend to have a higher risk of stroke than men for the same set of problems. So each of these conditions gets a point. Age greater than 75 gets 2 points, and previous stroke gets 2 points, and then you count up the points, and based on the point score, we can estimate your risk of stroke. And in this table, you see what it roughly is. So if you have just 1 point of those conditions, your annual risk of stroke is 1.3%, with 2, 2.6, and it increases as you get to 9. So most people will have, high blood pressure and are, say, greater than 75. They will have a CHAD score of 3. So that gives you a 3.2% risk of stroke, which might seem to you as not too bad, right? 3.2%, not too bad. But what you need to understand that it's an annual risk of stroke. So it adds up over years. So this a graph on the other side shows you what happens over a course of 5 years. So this green line here shows you if your CHADS VAS score is between 2 and 4, by 5 years, you now have 10% risk of stroke. So by 10 and 15, it multiplies further. For that reason, it is very important that people with atrial fibrillation be on blood thinners. A lot of patients hate to be on blood thinners. Blood thinners complicate your life. They make you bruise easily, you get nosebleeds. And if you're on the traditional blood thinner, which is warfarin, you need to have your blood checked. But if your doctor tells you to go on a blood thinner, just remember this graph. That's the reason why we recommend it. Today, we have newer blood thinners. Warfarin is actually a rat poison. You basically give it to a rat in a high dose, and then the rat bleeds internally and dies. So we give it to you in slightly lower doses than that. But nonetheless, you need to have your blood checked. And the reason why you need to have your blood checked is that warfarin needs vitamin K to work. Vitamin K is present in green leafy vegetables. So if you're on warfarin and you decide to have lots of salad, you need to take more warfarin. If then, for some reason, you don't need salad for 2 weeks, your blood becomes too thin. So this is what makes therapy with warfarin problematic. We now have these new anticoagulants, and some of you may have heard of them. Some of these you may have seen on television because the companies who make these are being sued. That is pure money making. All of these new blood thinners are more efficacious than warfarin in preventing stroke and have fewer bleeding problems. So they're undoubtedly better than warfarin. Warfarin's not being sued because it's generic. So when you see these, when a doctor wants to put you on Xarelto, and you've seen commercials about if you have bled, give us a call and we'll get you some money, it's really not related to data and medicine, but it's related to opportunities of making money. The biggest downside of these is that they don't have a reversal agent. So if you have a major accident, if you're in a car accident and you have major bleeding, it is more difficult to stop the bleeding if you're in one of these. Pradaxa now does, and very shortly all of them will. But as for now, to me, the one valid reason to not want to be on the new blood thinners, but to opt for warfarin, is that they don't have a reversal agent. Also, the cost is pretty different. So if your drug plan does not support these, they will run $350 a month. Most insurance companies now do support them. Once you have atrial fibrillation, the way you're treated depends mainly on the symptoms that you're having. Atrial fibrillation may or may not cause increased mortality, but it's not a deadly rhythm like some other rhythms are. There are people who live in atrial fibrillation for decades. If they're not terribly symptomatic, we can simply give them drugs that slow down the heart rate so it doesn't race. But if patients are symptomatic in fibrillation, then you want to correct the rhythm. So rhythm control means that you do something, either drugs or an ablation or any kind of therapy, that returns you back to normal rhythm, which is delineated here on this bottom line. And this irregular heart rhythm is fibrillation, which is rate controlled. So rate control is the kind of traditional way to treat atrial fibrillation. Up until, say, 10 years ago, everybody with atrial fibrillation was treated with a rate control. Here on this left side is atrial fibrillation with very fast heart rate. And on this right side, there's still atrial fibrillation. You see it's irregular, but the rate is fine. The pulse is fine. If you have the EKG on the left side, you're very unlikely to feel well. If you have the EKG on the right side, you could be quite asymptomatic, even though both show atrial fibrillation. For those patients for whom we want to restore normal rhythm, two broad avenues of therapy are available. You can either use antiarrhythmic drugs, or you can use an ablation. An ablation can be done in two ways. It can be done with radiofrequency catheter ablation or balloon cryogenic ablation. So in order to understand fibrillation, you need to understand normal rhythm. The heart has its own wiring system. Instruction to have a heartbeat comes out of this structure over here, which is called sinoatrial node. Sinoatrial node beats on its own. If you were to take a heart out of an animal and perfuse it with blood, it would not be connected to any nerves, it would not be connected to the brain, it would beat on its own. So the sinus node generates heartbeats on its own. Once the sinus node generates a heartbeat, the signal first activates the top chambers and then inscribes on your EKG this little bump here, which is called a P wave. The signal then goes through the AV node and activates the bottom chambers and then inscribes on your EKG this deflection, which is called a QRS complex. And it's very important that you have this one-to-one relationship between the top chamber activation and the bottom chamber activation, because the blood is pumped into the body by the ventricles, but the atria fill it with blood. Without the atria beating, the ventricles are less filled with blood and therefore eject less blood. So the one-to-one relationship that you achieve by having sinus rhythm is very advantageous for you. Fibrillation means that the top chambers are in a chaotic rhythm. They're not contracting in an organized fashion. It causes the swirling of blood, which I described, which then causes clots. But most importantly, the atria do not contribute to the filling of the ventricles. Therefore, the ventricles beat, but they're moving less blood with each beat. It is sort of like if you wanted to move an amount of dirt and you used a truck. If you fill the truck only halfway, you will need to make twice as many trips to move the whole amount of dirt. The atria allow you to fill the truck all the way so that each trip with the truck is as efficient as possible. So atrial fibrillation comes from the left atrium, three-dimensional reconstruction of a heart from a CT scan. And this happens to be my heart 10 years ago. So I'll kind of play it for you. It rotates. So this is right ventricle, left ventricle. And on the back of it is left atrium. This is left atrium. And normally there are 4 pulmonary veins, 1, 2, 3, 4. I happen to have a 5th pulmonary vein over here. About 20% of people do. If we look at the heart from the side, what we see here is this little sac, which is called left atrial appendage. This is where the clots form that eventually cause stroke. In certain surgical procedures, the left atrial appendage can be excised, which reduces your risk of stroke. But the left atrium is where atrial fibrillation originates. And specifically, the left atrium originates from the pulmonary veins. So here is sort of a computer electrical map of the left atrium. And these little stars represent the irritable spots that fire. And these signals that fire from the pulmonary veins collapse within the atrium and lead to a chaotic activation that's no longer organized. And so if we want to treat fibrillation, we need to in some way address these spots within the pulmonary veins, which are the original cause of fibrillation. The drugs, which I had listed for you on a previous slide, are designed to suppress this firing from the pulmonary veins. But a better way is to prevent the firing from conducting into the atrium, because the signal has to conduct into the atrium and then collide and become disorganized within the atrium. So if you can devise a method of stopping these signals from exiting the pulmonary veins and entering the left atrium, then you can achieve something good. This is sort of a cartoon of a left atrium. And here's a catheter which is inserted into the left superior pulmonary vein. So superior and inferior simply means that it's higher versus lower. It has no value judgment. So this circular catheter has a bunch of electrodes. And these electrodes are recording what's happening within a pulmonary vein. And the signals from the pulmonary vein are here in blue. This yellow catheter is in the right atrium. So this electrode here is nearest the sinus node and therefore activates first. So this is a normal sinus beat. So it originates in the right atrium and then it conducts all the way into this pulmonary vein. And what happens here is that you see that the first activation on this beat is up here. Now on this beat, the first activation is in the pulmonary vein. So that is a single beat which originated in this pulmonary vein. It was recorded by this catheter as the initial activation. And then the rest of the atrium is activated backwards. You see it when it's normal, it activates starting here and ending here. Now it's activated backwards because the signal comes out of the pulmonary vein instead of the sinus node, which we showed previously. So what we want to do is somehow stop this kind of beat from conducting into the atrium. Here's actually a similar situation. Here's a sinus beat, and this thing LSPV means this is a catheter in the left superior pulmonary vein, and the different electrodes are in these different lines. And you see the last normal beat, and then again the first activation is within the pulmonary vein, and it starts atrial fibrillation. The goal of an ablation procedure is to somehow either cauterize or freeze or in some way disable the tissues around the pulmonary veins such that when a beat comes out of the pulmonary veins, it doesn't conduct all the way into the atrium. So how do you do that? Well, first you need to get into the left atrium. What you do is you get access into the big veins in the groins. And if you have access into the central venous circulation and you push a wire into the heart, that wire will end up in the right atrium. Now you can see that unfortunately there's a wall between the right and the left atrium. So you have to create a hole in this wall in order to get into the left atrium. That's a little tricky, but it's doable. So here is actually a catheter which is now up against this wall. And here's an ultrasound showing that the catheter is tenting this wall. Okay? Here's the ultrasound catheter on the X-ray image, which is taking this ultrasound image. So once you are tenting this wall, you can advance a tiny wire, which then goes into the left atrium like that. And on ultrasound, it looks like this. So this wire is so tiny that even if you go into the wrong place with it, you can just retrieve it back and nothing bad will happen. It's sort of the size of a hair, but it's a strong wire. Once you have it there, you can then advance a needle and this whole big plastic tube into the left atrium and pull it all back. This is probably the riskiest part of this procedure, because if you point this in the wrong way, you could potentially place this outside of the heart and create a big hole. Once you have this tube in the left atrium, then you're home free. Then you can, through this tube, you can advance any catheter you like. So you generally start out with a circular catheter that has many electrodes around it, and you create an electrical map of the atrium. So wherever this circular catheter touches the heart, because the heart is electrically active, it will record an electrical signal. And a computer system will record this point. So each of these green points that you see on here is a place where one of these electrodes has touched the heart. You see there's thousands of them. So what you basically do is you take this catheter and you move it all around the left atrium, almost as if you were painting the inside of the atrium with this catheter. And you collect these thousands of points. And each of these points, the computer system will remember its three-dimensional position in space, and then will also record the electrical activity. And it can give you the amplitude of the electrical activity, that is how large is the signal. And it can also record the sequence of activation, meaning that if this point activates before this point, the system can color code it for you so that you know which point activated before another one. Once the computer system synthesizes it, then you get an image like this. So this is a back view of the heart. Here are two pulmonary veins. And this is sort of a large pulmonary vein trunk, which later subdivides into two pulmonary veins, but the part that attaches to the heart starts out as a large trunk. So now, on this particular view, we have displayed voltage. We have displayed the size of the electrograms. And the purple means that there's a healthy heart, and colors other than purple mean that the size of the electrograms is smaller, and it represents usually a scar. So in this particular patient, there's a little scar on the back wall. And now you're ready to prevent these signals that are causing atrial fibrillation from exiting the pulmonary veins. You can do this in two ways. You can either take an ablation catheter, which you can put up against the inner lining of the heart and pass electricity through this, and it will cause a small burn. And then you can go around the whole vein until you encircle it, and you stop the signals from going in and out. Alternatively, you can do this in one shot by pushing a balloon up against the pulmonary vein and then filling it with liquid nitrogen and freezing the vein in a single shot. Both of these techniques are pretty good, and they both have vulnerabilities. The balloon seems more efficient, right? You just do the whole, instead of having to do point-by-point lesions, you just do the whole lesion in one shot. But you see that this balloon is sort of an ellipsoid. And in this particular cartoon, the heart is drawn as having nice straight lines. But in reality, the heart has an interesting topography. There's little hills and valleys. So you can't be sure that this balloon fully adheres to the entire surface that you need. You can, ablate, freeze part of the tissues, but if the contact wasn't perfect, the tissues can recover, and then atrial fibrillation can resume. Catheter ablation has a similar vulnerability. You can do point by point, but once the lesions heal, you can ultimately have little gaps in the line, which can be a cause of a failure of a procedure and a requirement for a second procedure. So if you're doing this with radiofrequency, catheter-based, this is what it looks like sort of on X-ray. You have your circular catheter measuring, and then you're going around the circular catheter and ablating. And the system puts red dots where you have already ablated. And so you're working within this kind of electrical model that I've already shown you. Balloon, kind of similar. You put it up against the wall. How do you know that it's adhering? Well, you inject dye into the pulmonary vein, and if the dye is not leaking out, then you have a good seal. This is actually a procedure I did a week ago. And so here we're trying to isolate the left lower pulmonary vein, and so I place this balloon up against the pulmonary vein, and I inject dye, and you see it's all leaking out. So if we went on a freeze, it would be ineffective. And then on this picture, so I readjust the balloon, and now on this picture we inject dye, and it's hanging out in the pulmonary vein, so we can go on a freeze. And this freeze will isolate a pulmonary vein. And after you're done, you can remap your atrium, and now, you know, this was the initial map, and now you see there's gray behind these lines. That's because there's no voltage, because the pulmonary veins are isolated. So that's how you know you're done. If you have streaks of voltage going into the pulmonary vein, then you're not done. This picture you've already seen. This is a beat that was recorded by the circular catheter in the pulmonary vein that conducted out into the atrium. Now look what's happening here. Here's a normal beat. Here the pulmonary vein fires, but it doesn't go into the atrium as it did here. The pulmonary vein fires, but the atrium doesn't even know about it. And that's when you have a cure of atrial fibrillation on your hands. So this is again the circular catheter recording from the pulmonary vein, and this is a catheter recording from the atrium. And as you're going around the vein, you isolate the pulmonary vein, and suddenly the atrium goes into sinus rhythm, and the pulmonary vein, you see, continues to be in fibrillation. But it is no longer electrically connected into the atrium, so the patient is in normal rhythm. That's the goal of what you're trying to achieve. All right, so that's kind of the demonstration of how it's done. But a pacemaker is not a direct therapy for fibrillation.
Ablation is your first.
Ablation or drugs, or if the patient's not very symptomatic, just blood thinners to prevent stroke, and you can allow fibrillation to happen. All right, great, thank you.